Good afternoon, everybody. Hear me okay? Yeah, okay, great. We're going to go ahead and get started. It's my honor to welcome everybody to this week's edition of Talking Public Health. Thank you for those of you who are in the room and for everybody who is joining online. Today's speaker is Sara Malone. She's an assistant professor at the WashU School of Public Health. She received her doctorate in public health sciences and her master's degree in social work at Washington University's Brown School. She is a licensed clinical social worker and has worked in a variety of pediatric hospital settings. Her experiences in those settings continues to inform her research, which is aimed at understanding how teams, particularly those within pediatric healthcare systems, can best implement and sustain evidence-based programs and practices to improve the delivery of healthcare. Her research sits at the intersection of implementation science, the study of how to get evidence-based interventions, practices, and policies into routine use, and systems science, the study of the properties and interactions of complex systems such as health and hospital systems. At the School of Public Health, Sara co-leads the Health Design and Impact Lab and is a member of the Center for Public Health System Science. She has been funded by the National Institutes of Health, the Agency for Healthcare Research and Quality, and the Centers for Disease Control and Prevention, and the Department of Defense. Please, everybody, help me welcome Dr. Sara Malone.
I think I'm good. Am I? You guys hear me? All right. Hi. Thanks for joining. If you just came in and you want some food, please come get it while I talk. But it's great to be here with so many of you, both in person and online. As Angela just said, my work often sits right at the intersection of implementation science and system science. And usually, or often when I give talks, I really focus on those methods and how we use them to understand healthcare and health delivery. But today, I'm going to orient a little bit differently. I'm really starting at and hopefully returning to focusing on systems that deliver care for children. And so for colleagues and students who are used to hearing some of my work, this might sound a little bit different than some of what you've heard me present before, but I'm really hoping to focus on a few examples of current work and how they come together in a research program that's really aimed at improving pediatric care. And so when we mention pediatrics, you might have an image that comes to mind, especially people who have children or have been to a pediatric setting recently. So you might think about a lot of color, a lot of joy. I think a lot about the animals that are on the wallpaper, probably in the pediatric setting. And so I am talking about those clinic settings, but I'm also going to talk some about different kinds of care delivery. And so to do that, I'm first going to talk about two children who might encounter the healthcare system. So the first kid that I'd like for us to think about together is 5 years old. So she just started kindergarten this fall. She loves horses. She's probably learning to read, but she also is currently being treated for leukemia. So for those who don't know, leukemia is a form of cancer, which has pretty high rates. It's a pretty common childhood cancer. And her care then depends on many specialists. So it's no longer just a visit to a clinic to get a vaccine with a nice animal on the wall, but she's now dependent on oncologists, nurses, pharmacists, social workers, her family, her school support system, which are continuing to monitor for her symptoms, organize her care, and to try and keep her safe and result in survivorship. The second kiddo that I want us to think about is 8. That makes him second grade. We can tell that I have a younger kid, second grade. And he has asthma, and he often comes to St. Louis to receive his care, but he actually lives 2 hours away. So while Tim McBride is not here to tell us exactly what that does to his risk of being in what I'm calling a rural setting for the case of this example, let's say that one night he's with his friends, he's with his family, they're enjoying the fall, they're making s'mores around a fire, and he ultimately has an asthma attack. His family has to take him to an emergency department, so they go to the closest one that's available. That hospital is a good hospital, but it's not designed to take care of kids. It's not a children's hospital, and they're not able to understand the care that he usually receives when he's in St. Louis at the children's hospital because they don't have access to the information. So we have 2 children, we have 2 conditions, and their outcomes depend not just on their diagnosis or not just on the regular and routine care, but how the systems that surround them come together to provide care when they most need it. How well the emergency department that night is prepared. How well the specialists might communicate with each other. How well we follow up after discharge. So this is the story of pediatric care that I'd like us to think about as we move through the talk today. So children's health is created, as most of you all know, within these complex systems. And when we talk about improving child health, while we often talk about medicines and discoveries, many of the biggest gains that we see today in how children survive and how they're treated are because of how we organize care, how we communicate about care, and how we support both patients, families, and clinical teams in thinking about healthcare. And so this talk is about those delivery systems. And so I'm going to convince you, if you're not already convinced, which that'll make my job easier, that children's health is not simply a product of individual behavior or family behavior, but is a function of the system in which they receive care. And so I'm going to talk about how healthcare is shaped and how we study health to understand the impact it has on children. I'm going to talk about this in a variety of different ways and across a couple different levels, but the goal here is to imagine a system that we've designed together where children can receive the care they need when they need it by a team that's well equipped to provide it. So what's at stake? Hopefully this is the most grim part of my talk. It's headed up from here. But across the world, around 4.8 million children died in 2023 who were under the age of 5. And another 2.1 million children between 5 and 17 died. This is data according to UNICEF. And these I'm not going to spend a lot of time talking about this, although I'm happy to if people want to. These deaths, as you might expect, are not evenly distributed across many different categories: where you live, all of the social determinants that we know to impact outcomes and health. So they're not evenly distributed, but child mortality is decreasing globally. Annually, year over year, less children are dying, which means that even when we're not thinking about mortality, more children are living with chronic conditions or the after effects of having had disease. There are more children living with mental health challenges, the long-term effects of serious disease, and a lot of things that require continued healthcare and continued need to interact with the healthcare system. So let's look at it slightly differently. If we're not just looking at mortality and morbidity, let's think about access. We often talk about healthcare access. So how are children using healthcare and their families using healthcare? Children account for almost 6 million discharges each year, which is about 15% of all inpatient stays and subsequent costs of healthcare. The most common reason for hospitalization is newborn care, although there's many different things that cause a child to need healthcare or a hospitalization, some of which you all are familiar with. In addition to inpatient admissions, emergency departments see more than 30 million visits annually, which means, parents in the room, 1 in 5 children need to go to an emergency department every year to receive care. Someone in here is taking their kid to an emergency department this year. And it's true that children with chronic conditions are disproportionately represented. So something we know, something we've studied in a variety of different places, and some of my colleagues have talked some about this in their talks this fall. But about 15% of US children have a chronic condition, and they account for about 50% of the hospitalizations and subsequent costs. So each of these represents a time that someone comes into contact with the healthcare system and needs someone to understand what's wrong, figure out how to help, and deliver treatment that can help kids and their families get better. So we know that whether it's respiratory illness or sepsis or cancer, we have an opportunity to understand how we improve the delivery and improve outcomes for kids and their families. And we've demonstrated this in previous work. So again, I'm not going to go into this, but there's a lot of literature showing that when we standardize care, when we coordinate teams, we can improve outcomes. And those differences aren't necessarily about the child. In one study of pediatric sepsis, the mortality across the same case mix of patients ranged from 1% at one hospital up to 12% at another hospital. And the patient, so the severity of illness was not different. This was representative of everything else that was happening in the hospital and the ability to improve care. And in the Children's Hospital Solutions for Patient Safety, which is a widely popular collaborative, they were able to reduce serious adverse events. So the events that we would count as falls or other adverse and patient safety events, they were able to reduce them by 62% simply through an implementation effort in the collaborative. So there are ways to improve health within these systems, and that's the work that I'm really interested in answering. So how do we understand what's happening and how to improve care so that every time a child encounters the hospital or the healthcare system, which is a lot, we're able to provide high quality care. And so I think the first thing that we need to understand is what's actually happening for kids and their families. So the healthcare system is often, I think when we talk about it, feels a little abstract, but it's not abstract for kids and these families. It's a series of interactions. It's the clinic visit. It's getting medicine. It's the experience of sitting in a waiting room or the way that we describe illness to kids. And so in order to understand what's happening, we must start with what's happening for kids and their family. And so one of the ways that we've attempted to study this and have begun to understand what's happening for kids and their families is through understanding stigma. So this is particular to pediatric cancer. So for children who have cancer, we wanted to understand what the experience of stigma was like. And so stigma, I think most people are familiar with it, but we often think of stigma as a social phenomenon of othering someone because of a condition, because of a common element. So this is trying to understand how kids experience stigma with cancer. And we started by doing some qualitative work that I'm actually not going to present here to try and understand if stigma was more alike than different and what the experience of stigma was across a variety of settings. And we know, we've learned through our qualitative work that actually there are similarities to how kids experience stigma regardless of where they were. So this work was conducted in Guatemala, in Jordan, and in Zimbabwe, trying to understand what it looked like. In doing that, and in trying to understand how kids and their families experience stigma, we asked patients and their caregivers to fill out 2 measures of stigma that had been previously created and validated. And you can see them here. So on the left is the SSP, and on the right is the SSCI, which are 2 stigma measures that I'm happy to talk more about if you want to. On the left is the parent rating of stigma. They were using a proxy measure, so how parents rated the stigma that their child experienced. And on the right is the patient themselves and their rating of stigma using the same measure. There were 2 things that we discovered through doing this work. One is that these tools had to be widely adapted and changed in order to function across these different settings, not just translation, but actually to apply in the settings. And the second was quite a large amount of inconsistency between the responses from patients and the parents, which like many good research questions, led to more questions, which was, can we actually understand the experience that kids are going through when they have childhood cancer, and can we do that across a variety of settings? And so to do this, we conducted a systematic review of stigma and health conditions. Overall, in the sample, there was just over 2,200 papers that we pulled information from, and there was 2,605 tools used within the 2,200 papers. that is a lot of literature that we went through. Only 3% of those studies were on pediatric patients themselves in any way, not pediatric cancer, but pediatrics broadly. And there wasn't a common way to answer this question. And so after doing this review, we spent a lot of time thinking about it and decided we actually did want to create another tool, even though there were 2,600 of them. We weren't actually satisfied with any of those. And so we we pulled all of the items from the 2,600 tools that we reviewed, and we did concept mapping. So in the bottom right is a concept map where we asked people about what the experience of stigma was. We asked them to tell us what the stigma experience for children was like, and we grouped them by common domains and had people rank them and prioritize them. And so in doing this, we've been able to create a patient tool of stigma and a caregiver tool. So it's not a proxy tool. We're asking caregivers about themselves about the experience of stigma, and patients age 8 to 18 about the experience that they have of stigma as they go through pediatric cancer and cancer treatment. And in doing this, we've been able to create a tool that's in Spanish, English, and Arabic to try and measure stigma experiences across a variety of settings to understand if, in fact, the experience of stigma within the healthcare system is the same or different, and in what ways this might be different. And so we've developed this tool, and we're currently piloting it in Jordan, in Guatemala, and in the United States to try and answer this question. But in doing this, this is one example of many, and a lot of the work that's being done in the School of Public Health also around understanding the experience of patients within the healthcare system to understand how we can shape healthcare in order to improve these outcomes. So in addition to thinking about the experience of patients within the system, I think it's equally as important to consider the healthcare clinicians working to deliver care. And so all of the outcomes that we see, the safe chemo administration to a kindergartner, a resuscitation of an 8-year-old in the emergency department, smooth discharges and follow-up care, relies on communication and coordination amongst the healthcare team. And every gap in this is felt both by families and by the clinicians on the team. When care falls apart, it's something that everyone experiences. And so families might experience uncoordinated or care as poor care, as getting different messages from different clinicians. Clinicians might experience it as burnout or thinking about intent to leave. And it also results in inefficiency and harm. And so I really, a lot of my work is aimed at how we think about communication and coordination as an intervention itself, regardless of the care setting. And so we know, and I just talked some about, that effective team communication is important for high quality care. So over 70% of treatment delays, preventable harm, and death within inpatient settings are at least partially due to poor communication, and it's often a root cause identified in serious patient safety events. And we've studied communication historically through structured opportunities to communicate. So things like rounds or a planned instance where teams come together, or things like handoff. So when we go from day shift to night shift, how the teams communicate. Communication has been studied less through regular routine care, so ongoing care throughout the day or during acute events. And so this work is actually targeting understanding communication in those instances. So this is focused on children with cancer. When they're admitted to the hospital, they are often admitted onto the oncology unit, and they're monitored there. And after rounds, after vital sign checks, teams standardly evaluate patients for deterioration or a sign that they're getting worse and might need intervention in the intensive care unit, CPR, some level of escalated care. And so this work is really trying to understand how we communicate, both in routine care delivery, but also in instances of patient deterioration as a way to understand what's happening. And we've conceptualized communication, which is in the middle of the box on the bottom, as having two components that I'm going to talk about. So the first is communication quality, or the perception of how well people are communicating. And the second is communication structure. And I'm going to talk a little bit more about that. But really getting at the idea that we can understand things like power and hierarchy that can help understand what that means for how teams communicate. So to do that, first, we needed a way to understand how teams communicate around patient deterioration. And while there are many patient safety measures, we created a measure specifically focused on understanding communication and the aspects of communication that are important. And so this work, we also did concept mapping, but we pilot tested this with over 400 clinicians across different professions and disciplines. And this tool was originally created in Spanish and English, but has since been translated for use and used in the languages up there. And when we did this work, we learned that there were 6 domains of high quality communication that people perceived. And those 6 domains are if the communication is actionable and clear. So that's about the content of the communication. Do people feel like they can act on it? Do they understand what someone's saying? We also learned that communication has elements of empowerment. So if people feel like they can speak up, and of teamwork. There's also a leadership component to communication. So how leaders promote communication, how they make safe spaces for people to communicate. And then finally, and we will come back to this, people told us a lot about the tone of communication, both verbal and nonverbal tone of communication. Coming back to that. So we have surveyed individuals. We did a cross-sectional study, which now has just over 2,800 clinicians. We've used the tool in all of the languages that it's been developed to try and understand globally how teams communicate in this setting. And so this work involves many hospitals across many countries, and just under 20% of people said they either weren't sure or definitely thought that people with authority, defined as people in a power higher than them, weren't open to their patient safety concerns when they had them. So almost 20% of people feel like someone doesn't want to hear when they're worried about a patient. Clinicians who have practiced longer, and we could spend a lot more time talking about this, compared to those who have been there less than a year, which is important because there's high turnover within 1 year of being in a clinical environment, perceive communication as being both clearer and having a better tone. And then when we ask, respiratory therapists, when compared to their nurse counterparts, perceive greater empowerment around communication. And I think importantly, and again, we could spend a whole hour talking about this, communication quality amongst these clinicians is related to burnout and intent to leave. So people who perceive communication quality to be worse in their environment also report high amounts of burnout and a desire to leave their job. So this is a profile of those individuals across professions. And so it's meant to give you an idea of the profile. So the first 6 opportunities or the first 6 lines here are the subdomains. And the final one is an overall score. So this measure is calculated as a mean. And so you can see the overall score all the way on the right. And the idea here is not to spend too terribly much time with each of the individual dots, but to look broadly at this and to understand that there are differences. I should note that this is actually out of 5 on the Likert scale. There are differences amongst professions in how they report perceived communication quality. Tone, notably the worst. So we also are interested in understanding if this is different in different settings. And so we do have data on hospital type or size of unit, but I thought it might be interesting for this group. We looked at this by region. So we do have this data now across many different countries. And so we looked at region to understand if, in fact, there's different things happening with communication and how teams communicate in different settings. And so you can see again, there's some patterns here in how people perceive communication quality, but universally, even when communication is both actionable and clear, it doesn't feel great when people are identifying how they're concerned about it. And when you investigate that further, it is both verbal and nonverbal cues that people are concerned about. So it are things that people perceive to be what you might describe as outwardly hostile, but then also understanding what's happening with nonverbal cues and how they're perceived. And so there's differences in how people perceive communication quality. But if we go back to what I was talking about at the beginning, I perceive this to only be one aspect of what's happening in the hospital. And if we want to think about communication and coordination as something that we can intervene upon, I think it's important to understand what the structure of that communication looks like, because how it's perceived is only one piece of the equation. And so we conducted social network analysis, which is one survey method. We used a survey. It's one aspect of system science to understand who in the hospital was actually communicating with each other. And so we've done this now in 2 hospitals, but with plans to collect data from 20 hospitals to understand variations in communication structure. And so what I'm going to show you are just results from one hospital, but the goal ultimately is to be able to understand how we can relate communication quality to structure in order to design interventions. And so communication networks actually aren't uniform. They vary within the same hospital. They vary across units, although what I'm showing you is one hospital. So on the left, what you can see are people who endorse communication daily. And that is an important anchor for how we think about this. First of all, people in a hospital talk a lot to each other. That's one of the things we see here. The dots are people, the lines are communication saying, I talked to this person. So a lot of people within the hospital talk to a lot of other people within the hospital. But what we see on the left represents communication that is centered usually around rounds or around handoff. We facilitate within the hospital instances for healthcare teams to talk to each other one time a day, to make a plan, to think about what's going on with a patient. But what we see on the right is the same group of people talking about how often they talk to each other multiple times a day. And you can see, even if we don't go into numbers, many fewer lines between people. And I think this is important because what we start to see here are the opportunities to provide coordinated care or to communicate with each other in a way that is consistent throughout the day or to the needs of the patients. And what I am not saying is that it should look like it does on the left, on the right. I think there's still an open question about how to best structure communication and how to structure teams in order to communicate in a way that both results in high perceived communication quality and better patient outcomes. But this helps us understand what it looks like and how people communicate with each other and who might be driving communication, receiving communication, and then ultimately how we can design interventions to change the structure to better facilitate care. So related to that, we've talked about patients, we've talked about clinicians. Now we're going to move up a level. So I'm going to talk some about health systems. And so health systems currently in a variety of spaces are fragmented. What do I mean by fragmented? I mean, it's often difficult to transition care from inpatient to outpatient, from one specialist to another, from pediatrics to adult settings. There's many ways in which the health system is fragmented, and that extends some of what you just heard about communication and coordination. What I was talking about there was within a setting, but how it extends across settings. And so it is true that care for children like adults, actually spans clinical teams, locations, settings. You might go to one subspecialist group in hospital A to see someone in oncology, and you might go somewhere else to see someone in neurology. And what that means is caregivers and families often become advocates for their child and are responsible for navigating this care. Lots of phone calls, figuring out appointments, figuring out where to go. And this can, at its best, lead to delays in diagnosis or in treatment. I think at its worst, people stop doing it. They stop navigating the care system, and we see something that we might consider to be treatment abandonment or dropping out of care. And so the ultimate result here is that care is inefficient and unsafe, or generally just not as high quality as we want it to be. And so some of you who came to Mara's talk, I don't know how long it was now, a month ago, heard Mara talk some about this work, but we've actually been thinking a lot about how survivorship care can help us understand fragmentation of care. So trying to both improve care for cancer survivors, but also understand what this means more broadly for how we think about aligning care and bringing care teams together. And so the goal of this work has been to collaboratively explore and understand the complex care system that is survivorship care. And so for people who aren't familiar, the work I've been talking about is really active treatment during oncology care, but this is focused on once children are done receiving care, once they're off treatment, about depending on the program, 2 to 5 years after treatment, they're considered a cancer survivor, but they still need monitoring, surveillance, other sorts of screening, both to track and try and understand recurrence and secondary disease, but also the other complications that come after cancer and cancer treatment. And so in order to do this, we started with a question that was, how do we know what's happening in survivorship care globally? That is admittedly a large question, but really trying to understand, are there different models of what's happening? Are there places it's going well? And so to do this, while Mara talks some about the design elements we also use system dynamics, particularly group model building, which is a structured method to visualize a complex system. And so what have we done to do this? We've conducted 3 formal workshops to begin to answer these questions, 1 in the United States and 2 globally. And in addition to that, we've also done 30 semi-structured interviews with clinicians across 26 countries in order to understand what survivorship care looks like in their setting. And so most of this work to date has been with clinicians who are delivering childhood cancer, although we have work underway with patients and families about how they navigate the system so we can understand different perspectives of this. And we did formal group model building workshops. Some of the activities were behavior over time graphs. We looked at variables, and we did formal systems mapping. This figure represents some of the synthesis of our work on survivorship. And so a reminder, the question here is what happens when we step back and think about what's happening as a system and what's underlying the system of what we see. And so each of the things on the screen are variables or aspects of survivorship care that people perceive to be important, and the arrows represent a relationship between those. And so these were identified through a variety of ways, but what I have highlighted at the bottom right is helping us understand really aspects of access, psychosocial care, things about insurance, and how they interact. So whether or not patients can actually access care, that's in the bottom right, and then the result of that on the capacity of the organization to provide care. And so you can see that there's patients who access care result in more numbers of survivors engaged in care, which ultimately is a good thing. That's what we're striving for. But when we do that, we also have to recognize that it's increasing clinician workload, which decreases the amount of time that they can spend with patients, which might decrease the quality of care provided, which might then mean a patient doesn't come back to their visit. And so that's what we call a balancing loop, or something that we have to think about that might be an unintended consequence of just trying to increase access to care. And that's just one example of what we're trying to understand about how isolated improvements might impact the system and how these connections actually drive the behavior that we're seeing. Currently highlighted is an aspect of the system that's really around some of the care delivery models and how care is shaped and resourced. And so this is really about organized care and what we see around how we prioritize resources if we develop independent survivorship clinics and what the behaviors are that happen there. And so really, one of the questions that we're wrestling with here is what happens when we have positive outcomes that we're looking for. We want more patients in care, we want more care clinics, but it's creating a capacity strain, which ultimately can be a quality problem for how we deliver care. Again, up here now we see the drivers around advocacy, and so how we prioritize. And so this starts to get into some of the ideas of policy that I'm going to talk about in just a minute. This further extends the policy aspect. So what does it mean to have cost and insurance variability across settings? So we have collected this data both in places that have insurance programs that more reflect the United States, places that have universal coverage for care. There's all different kinds of care models that what we're trying to do is actually not ask questions independently about insurance or the structure of the clinic, but to understand more broadly what's happening and what the factors might be at play, so we can think about how to design care models, regardless of where you are, that can promote the kind of high quality care we want. And then finally over here, I just wanted to highlight that there's actually a huge part of this that relates to patient advocacy and organizing. And so I know I started this talk with the perspective of patients, but we see it throughout the kinds of work that we do, that there's really important aspects of how patients engage with us on care planning, and on the experience of care that can actually drive how the system is providing quality care. And so again, for the sake of time, to sort of distill this down, as we looked about this, we found actually, maybe surprisingly to us, maybe more surprising than we thought, that there were actually many more commonalities than we thought. When we started this work, we were really thinking that what we might find is a story where there's different models of care, there's different structures of care, but no matter where survivorship care is occurring, in environments that have many resources, like you might think about locally, or other places where survivorship care is really emergent. We heard things in some of our qualitative interviews like, we've just now gotten survival to a place where we can even think about survivorship care. But the same core sectors, and these are probably not totally surprising or unfamiliar to you all, but these core sectors really shape outcomes and the way that we're able to organize care across a variety of spaces. And so while we might see place-based variations that unfold, these systems are more alike than they are different. And so it allows us to start asking questions like, what happens when we have a high level of capacity for clinical teams, but we don't necessarily have traction in policy? How do we think about the way that that manifests and impacts the care that we're providing? And so I think this is one of the key insights here that we're thinking about is fragmentation is not just that resources are missing. I think often we tell a story in some of these care delivery settings that is, if we had more resources, if we had more staff, then we would be able to solve this problem. But really, what we're seeing here is it's not just resources that are missing, but there's other dynamics at play that we can start to think about some of the coordination and how to improve care. And so, just a few more points, and then I'm happy to engage in questions or talk more about any of this that might be interesting. I think really the work that we're trying to do is in these examples is how we can think across levels about improving care and really understanding what's happening in order to design interventions and design different opportunities or tools to help provide solutions. And so really, this is where I'm going to pivot a little bit and talk about the work that we're sort of launching. But I think this year, one of the exciting things that has happened is that Mara and I have been able to launch the Health Design and Impact Lab. And it's really predicated on some of these ideas that we have to be able to think about data, how we use data, but also design together in order to improve care. And so really thinking critically about what data is available to us and what we know about what's happening, but also design principles to help us think about how we could do it better. And so together thinking about what it is to provide safer care. And so one of the things that I think is unique about pediatric care is that it really, it's time limited. And so if I were giving an implementation science talk, I would probably tell you that there's discoveries that we know today that actually won't be in routine care until a child born today is already an adult. But I think this is also true in a lot of the work that we're all doing around improvement and how we think about how these systems unfold and change over time. So it's not just about one intervention and one implementation, but we live in a time, we have a time with a wild amount of health data. I think the question that we're facing today is not necessarily like, how do we think about that data, but how do we get it? How do we use it? How do we make it something that's actually meaningful? So, you know, the hospital today is generating millions of data points, probably more than that. And that includes, you know, medication log, it includes vital signs, but it also includes patient satisfaction surveys. It includes a lot of information that we need to sort of figure out how to harness. And so I think one of the challenges that we're facing and that we're thinking about is not necessarily a lack of data or a lack of engagement, but how to connect the data with design in order to result in action. And so we have launched a lab to think about this and to think about how we can both design systems and interventions to work for patients and clinicians and systems. And so I am excited about that. And if this work is exciting to you, you should come find us and we would love to collaborate with you. But I think one of the things that I wanted to highlight was that this work is really designed to work at the bedside. So a lot of the work we're doing around design, around data, you've seen, you know, some survey data collection we've done, some network data collection we've done, but all of the work we're doing is actually designed to serve clinicians and patients and families in ways that are actionable. And so this includes work that we're currently doing to create a clinician-facing tool in order to understand adaptive care guidelines and how to receive guidelines for care that is actually appropriate for your setting. It also includes ways to feed data back to clinicians around things like communication quality and how clinicians in their site perceive communication in order to improve communication. And so really the work that we're doing is meant also to go back to clinicians or to go back to organizations, not just at the bedside, but people who are decision makers, people who are policy makers, so that we can actually make better decisions as we're taking care of kids and as we're thinking about improving care for kids. And so my final idea here is that advancing child health actually means that we need to design systems that are intelligent, they're responsive, that are well integrated, and that they're compassionate and responsive to what kids and their families are going through. And so I think it's often easy to focus on a new intervention, a new therapy, and implementing that. But really, I think what I'm trying to articulate, hopefully, is that what we need to understand is the system that can apply these interventions, that can integrate these interventions, and that can continue to deliver care that is high quality, highly reliable, and equitable. And I think being able to think about both systems that can learn and adapt and those that can align across teams and across disciplines is a way to actually think about how we can deliver continuous care regardless of disease, regardless regardless of child, when they encounter our healthcare system. And so this is the work that I have set out to do and that I continue to do. And so if this is something that's interesting to you all or relevant to you, I hope you will find me now or after so we can think about ways to do this together. And with that, I think I've left time for questions. Thank you.
Here we go. While everyone is thinking of their questions, I just want to jump in with 3 quick housekeeping things. And first of all, thank you for that talk. That was fascinating. 3 quick things. For the students that are here as part of public health seminar, the QR code for your sign-in should be working now. So be sure that you sign in so you get your participation points. The second thing is that there is a class in here that starts at 1 o'clock. So we'll take questions and we'll try to end a few minutes early out of respect for that class. And in that spirit, we will have to pack up fairly quickly once we're done. So if you have not gotten food yet, please feel free to come down and grab some food while Dr. Malone is taking questions. Thanks. It's still not working. Okay, well then everybody gets participation points. Free. Yeah. I said so. Okay.
Yeah, don't email me. You can email me other questions. Don't email me about your participation.
Right. Okay, questions?
Yeah.
Okay, and you should be able to speak loudly enough in here. The speakers will pick, or the mics will pick up.
Yeah, go ahead.
Really fascinating and important work. Thank you for sharing it. I was wondering, I had 2 questions. Like, one is that, we live in the US where we have this quirky for-profit healthcare system that's tied to our work. Like, a lot of us get healthcare benefits through work. And so I'm wondering, any places across the globe that are doing this well, like communicating well, and also just wanted you to comment on racial and socioeconomic inequities and communication.
In team communication? Yeah, good questions. Okay. Are there places that are doing it well? Yes, and we're on a hunt to figure out exactly where those places are. So there are places that are doing it well, and I think importantly to the concept I was presenting, there's places that are doing it wildly different than the United States is. And so I think, in the US healthcare system, we have these different teams who operate in different units that are sometimes physically separated. And so there's structure of that communication, right? It goes to an attending and then it goes across to the other unit and then it might go down. And that's actually not the case everywhere. And so I think there are places where people perceive quality to be better and the structure is wildly different. And so that's one of the things we're currently set out to understand is how we can maybe not totally upend how we deliver care. I think that might be too ambitious, but understand what it is that facilitates that going better or well. And so, yes, and differences in communication. So we have some information on like social determinants and other things that might change communication. But I will say that when we conduct this work globally, what we see is actually not necessarily individual differences, but cultural differences in communication and how communication exists and how people are socialized into communication that translates into the healthcare system. And so while there are sort of these individual determinants that are certainly present and we need to think about, often what we see and hear about more strongly are just general cultural differences and professional socialization differences to communication. But we do have some of that data and could certainly talk about it. Yeah. Yeah, go ahead.
Is there any interventions or any interventions from the Impact Lab that you were excited about?
Yes, many. That's a good question. Should I bring Mara down here and talk about it? So I think, yes, the one that we're currently working on, I'll talk about that because I am excited about it. So we're currently designing this online platform where traditionally evidence-based guidelines come out and they're gold standard guidelines, and they are what they are, and they live in a sort of static world. And we are creating an online tool for clinicians to understand if they don't have certain resources or if they cannot achieve the gold standard guidelines, what's the next best care. So an easy example of this is in order to deliver this intervention, I'm supposed to have an MRI machine, but I actually don't have an MRI machine in my hospital. So what am I supposed to do? And so this will, with expert opinion, give an answer to that question. And there is work that's being led by Mara and others actually to also create this for patients, to think about what it would look like to have equivalent care tools, both for clinicians and for patients, that can then facilitate understanding, but also shared understanding and a dialogue around care planning. And I'm very excited about being able to understand what that looks like and how it can shape the interaction between a patient, family, and a clinician. And there's many more. Yeah.
Great talk. Very quickly, your last phrase on your slides was compassionate system. What's the compassionate system separate from the people in the system?
Yeah, that's a very difficult question. Thank you. I think, I think it's a lot driven by the people in the system, but I do think that there's ways that we can design elements of care, how you like show up into a clinic, what scheduling looks like, what hospitalization looks like, that's more than just the people in it and results in care that is more, to use simple language, patient-oriented. And so I think in order to do that, we need to potentially have less rigidity in the way we've thought about what it looks like to have a care encounter and receive care and interact with the system. You can tell me later how you feel about that answer. Yeah.
So thank you for mapping all this. I guess what I'm curious about is often how it's discussed is you have patients or parents on one side and the clinicians, providers on the other. But many times there's that shared and lived experience, that crossover between, especially in areas that don't have a lot of different care. So they're both patients in those settings and potentially workers in those settings too. And I'm curious about how that's shaped some of especially like the concept mapping and areas that you want to work in, how, like, because I'd imagine that's come up in the qualitative work that you've done.
Yeah, that's certainly true. And I will say that the team communication work that I presented here does not include patients and families because of the nature of the data collection. But we do have a whole line of this work that I did not present here, which is all on integration of patients and families into team communication, usually in the setting of rounds. But so yes, it overlaps in many ways. But I think a lot of the work that we do, we don't, like the stigma work, for example, we didn't ask people, we invited people that we knew were patients, survivors, parents, clinicians, but we didn't ask people to just answer from that standpoint. We asked people more broadly, and I think that's one of the beauties of concept mapping is you just ask people, you know, what does stigma for children with cancer look like? And how people answer that is certainly shaped by their experience, but it can be shaped by the whole of a person and the experience that they bring. And so that is certainly true with how people do this. I think it's also true, and I have less data on this, when we think about care delivery and we think about how clinicians think about providing care is certainly shaped by personal experience. If you become a parent and you're a pediatrician, you probably think about pediatric care differently. That is certainly true. It's not in the data that I presented here, but I do think it impacts how we, again, to go back to thinking about what it means to like be a clinician showing up to provide care and how you orient yourself to your job. Yeah, I'm keeping an eye on time. Any last questions?
You mentioned how communication during handoffs plays such a critical role in patient safety. From your experience, what are some of the biggest barriers that make handoffs challenging to implement effectively?
Oh my goodness, great question. There's a lot of them, and they certainly vary across setting. But when you a handoff, so just like orient people to how I'm thinking about it, you're in a hospital, there's a lot of patients. I've been working all day and I'd like to go home. Someone's been doing everything else they need to do all day and they're staring down a whole night shift, and I need to deliver a bunch of information. They need to receive that information, but at the same time, the family's getting there because the workday's over and they can come visit their kid, and there's a lot of things going on. And so I think in that environment, there's many things that just physically make it hard about who we are, the time of the day, the hustle and bustle. But I also think while we have some structured tools around how we hand off care and the way we talk about care, it's not, we don't always have the same shared mental model of what it means or what it looks like or what might be important information. And so I think there's a whole host of like physical and relational aspects that make handoff extremely difficult. But there are ways to do it better, and we're going to figure them out together. All right.
Thank you.
Thank you.